Dr. Luann Eads serves as the program director of the geriatric psychiatry residency, and she's assistant clinical professor in the UAMS College Department of Psychiatry. She's responsible for the oversight and organization of all educational activities within the geriatric psychiatry program and the monitoring of the progress of each resident. She also runs the inpatient geriatric psychiatry unit at UAMS PRI and sees outpatients in the rental center and has a specialty there of dementia. Dr. Eads received her MD from UAMS in, you want me to tell them, in 1996? It was just a minute ago. She completed a residency in geriatric psychiatry in 2000. And in 2001, she also completed a fellowship in geriatric psychiatry at St. Louis University. Dr. Eads is certified by the American Board of Psychiatry and Neurology and in general psychiatry. She has no personal, business, or financial conflicts of interest to disclose, and I'm done. Your turn.
I do run the Geriatric Psychiatry Fellowship. Just as a clarification, we used to have a geriatric psychiatry inpatient unit that has closed and gone to the women's unit. So I do still run the women's unit, and I run the ETC service in addition to seeing geriatric outpatients. So what I was asked to talk about today was what they frequently refer to as, I guess we need to start with this actually. The project is supported by HRSA, and there's the grant number. It falls under this category, the building blocks, and it's frequently referred to as the 3 Ds of geriatric psychiatry because this is the majority of what geriatric psychiatry deals with: depression, delirium, dementia. And they're not all exclusive. Frequently you have them all mixed together and you're teasing out which one's which and how to treat them best. All right, 3 Ds of geriatric psychiatry is delirium, dementia, depression. We have a new DSMV that took an effect in May of last year, 2014. And so the new term for dementia or cognitive disorders are neurocognitive disorders. And under that you'll find the categories delirium, and it's actually neurocognitive disorder, but most people know it by dementia. Okay, so we're going to start out with delirium itself. Characteristics of delirium by the DSMV criteria: it develops over a short period of time. It is a distinct change from the baseline. It fluctuates in severity, and it is considered a medical emergency. The longer you let this ride without treating it, the worse the outcomes, both in morbidity and mortality. Delirium symptoms. By definition, delirium is a disturbance of attendance and awareness, attention awareness. You have difficulty maintaining attention, shifting attention, screening out the extraneous manners, and disturbance in the awareness where you're at, time, place, location, that kind of stuff. All right, delirium symptoms. We're going to look at delirium from different categories of symptoms. First one we're going to look at is the cognitive impairment. And when we talk about cognitive impairment, we talk about impairment of attention, difficulty maintaining attention, shifting attention, disorientation to time, person, and place, and you actually lose your orientation to time first, then place, and then person last. Impairment of memory, and it's all different domains of memory: short-term, long-term, visual, spatial, executive functioning. The worse the delirium, the more impaired you're going to see the different domains. We look at motor disturbances. This is what most people remember about delirium. Is usually it falls into 3 categories: what's considered hyperactive, which is too active; hypoactive, underactive; and then a mixture of the two called mixed motor activity. The hypoactive usually is frequently kind of confused with depression. A delirious person that's hypoactive, they're usually quiet, not bothering anything, not creating any problems, sleeping, and so they frequently get missed for longer periods of time, and the longer it takes to diagnose the delirium, again, the worse the outcome. It's the hypoactive that comes to attention pretty quickly. Those are the ones that are pulling out lines, walking out of hospitals, those kind of things. And so those are the ones you get called on really quick. Do something with them now. Sleep is also affected in delirium. You frequently get your sleep-wake cycle is mixed up, a lot of day-night reversal, a lot of fragmentation of sleep, and if you do not sleep, then it just makes the delirium that much worse. So part of treating that delirium is trying to get that sleep cycle reversed and back to normal. Psychosis of delirium, frequently you see misidentifications. They're seeing a cord in the floor and thinking it's snakes. Illusions is another name for that. The visual hallucinations are usually more, the hallucinations are usually more visual in nature, whereas for a schizophrenic, they're more auditory. So when you hear someone talking about visual hallucinations, that's a clue that maybe this is something more like a delirium. Disorganized thoughts and speech would be another one. Affective mood changes, either it's a mixture of different changes. Either they can become very agitated and irritable and almost look manic-y to you, almost look like a manic person, or they can become very withdrawn and depressed, withdrawn and isolative and look depressed. And you can have a mixture of those. You can have one day they look hypoactive, and the next thing they're looking hypoactive, and it's a back and forth. And then language is impaired. A lot of times there's word finding difficulty, disorganized speech, trouble staying on topic, and following directions and simple commands. All right, delirium risk factors. What are the factors that kind of increase a risk of a patient developing delirium? Well, one of them, if we look at the patient risk factors, one of those is age. There's the two extremes of age are actually the high risk of delirium, the very young, newborn, first few months of life, and the elderly. The elderly has an atrophy of the brain, so the brain does not have the reserve that it did when they were 20 and 30. So the brain is at an increased risk in an elderly person who does not have a memory problem of developing delirium. And then when you put a previous dementia on top of that, that ups the ante. That makes it more likely that they're going to end up with some type of delirium if you're not careful. So dementia would be another risk factor. If they've had a previous episode of delirium, that adds to the risk of developing another delirium. So once you've had a delirium, you have a higher risk of developing another delirium. Anything going on in the brain, strokes, tumors, infections, any of that stuff will elevate the risk factors. Environmental risk factors, you want to think about deficits that's going to make the confusion and disorientation worse and kind of push you on into that delirium picture. If they are vision impaired, hearing impaired, that can actually add to their confusion and push you on over into that direction. So you want to be addressing their sensory deficits. Immobility, the longer you have them immobile in bed, the more restraints, the more lines you have, the more likely you are to have a delirium. The worse the delirium can get real quick. And then sleep becomes another issue. And so if you've got a person that's sleeping, the last thing you want to do is wake them up at 2 in the morning and give them a pill. You're just disrupting what you're trying to correct. Medical issues that we look for is frequently you do not just have one cause of delirium. Most of the time there's multiple causes. So just because you find one cause does not mean that you can give up looking. You need to keep looking, and everything needs to be corrected. They may have a urinary tract infection. They may have urinary retention. They may have sepsis. You've got to address all of these causes to really get control of the delirium. Infections you've got to treat. If they're hypothermic, that makes it harder to manage. If they're hypoxic, that makes it harder to manage. So do they have anemia? Do they have organs that are not functioning very well? Those kind of things. Surgical, we know that unplanned surgeries, emergency surgeries, and surgeries that go for long periods of time are associated with higher risk of delirium. Substances, Once people become elderly, you tend to think, well, you can forget about substances, but this is also the generation, the baby boomer generation, who likes substances. So, I still have patients that I do drug screens on that are positive for marijuana and some of the other stuff. And so that just because they're 65, 70 does not mean that they didn't use. But the more common than that is you want to worry about alcohol, benzos, and opiates. Those are probably the three substances, most likely substances, that can get you in trouble pretty quickly. If you've got a person that's gone to surgery and they're about 72 hours out and no one knew that they had problems with alcohol, there's a good chance you're going to wind up in delirium, tremors, and that is much harder to manage on the back end than it is on the front end. Benzos, nobody knew they were taking benzos. They were going from different doctors to different doctors, or opiates. And they're delirious, and nobody can find an obvious source of infection, and you go back and you pull the prescription profiles of all these different places, and they've had all kind of benzos and opiates that they didn't share with you, nobody thought was important, those kind of things. Other thing is, a lot of times people go and buy over-the-counter medicines, and they don't consider them medicines per se when you ask what medicines you're taking. And so if you're not careful, they'll wind up buying anticholinergic medicines that also make their memory worse, their delirium worse. Benadryls, Tylenol PMs, they don't think of those as medicines a lot of times. So, sometimes you have to get really specific in what you take and why are you taking it, those kind of things. I watch death as an easy mnemonic for a lot of people when they think about looking at trying to find the most common causes of your delirium. And I stands for infections. The most common infections you're going to see with the geriatric population are urinary tract infections and pneumonias. And it's not that uncommon to see a person that's had some urinary retention in front of that urinary tract infection. Withdrawals, again, be aware of substances, drugs, alcohol, over-the-counter stuff. Acute metabolic issues, electrolytes that are out of whack, hypoxias, those kind of things. Toxins and drugs, I think we've talked about those. CNS pathology, tumors, infections, hypoxias, we've talked about. Deficiencies. If they've got a long history of alcohol, then worry about thiamine deficiency. And you want to be real careful if they do have that alcohol history of getting thiamine in them before you start the IVs and that kind of stuff. Endocrine abnormalities, thyroids, parathyroids can vary, especially in an elderly, frail person, can look like a delirium at times. Acute vascular events, strokes, head injuries. Geriatric patients are really prone to fall, and a subdural hematoma is very common with them, and delirium follows that. And so, have you been falling? Those kind of things. Traumas, heavy metal. Okay, so how are we going to work this out? Well, probably the most important thing you're going to do is that physical exam, and the most important part of that physical exam is your history. You want to, and this is probably going to take you some time, because in order to really figure things out, you've kind of got to do the detective mode, and that means you're probably going to need to call family, you're going to need to call pharmacies, you're going to need to call friends, you're going to have to expand it besides just seeing the patient. First of all, they're too confused to provide you much information, and so you've got to figure out what their baseline is. Were they cognitively intact before they presented with this delirium? Were they a pretty advanced dementia? So we got to kind of have some idea what baseline we're trying to get them back to. What are their sensory deficits? If they need hearing aids, if they need glasses, we need to work on getting those sensory devices for them to help minimize the severity. And then again, drugs. You really got to know what drugs they're taking, prescription, over-the-counter, herbs, supplements. Those all make a difference in trying to address what's going on and minimizing the severity. Okay, so once you've kind of gotten your history and think you kind of know what the patient is and what the change is, then you want to look at it from a medical standpoint. What are the most common medical tests that you would run? Well, frequently people will look at CBCs, lights, calcium, mag, phosphorus, LFTs, glucoses, pulse oxes, drug screens, those kind of things. Those are pretty common tests to run with delirium workup. If you don't find much there, then you go to the secondary tests, which are the more costly tests. The brain scans, the CTs, the MRIs, the EEGs, spinal taps, blood cultures, those tests. So how are we going to manage a delirium? Well, delirium is rarely one cause. So remember, it's probably multifactorial, and so you need to go looking for all causes and treat all causes. You need to minimize the drugs that they're getting at that time. And you want to get rid of any drugs that could make things worse, any anticholinergic drugs. Usually we try to get rid of as many psychotropic drugs as possible because they cross the blood-brain barrier. We may add those back in later, but you want as many drugs out of the picture as possible. The more drugs you have, the more likely you are to have a drug-drug interaction, and the harder it is to stabilize things and get things turned around. There is no FDA drug approved to treat delirium. So when people think of treating delirium with a drug, it's usually the safety issues. Is this person so delirious and so disorganized in their behavior and thoughts that you cannot manage them and keep them safe and everybody else safe without some kind of a pharmacological intervention? And that's usually where you come in with your antipsychotics. Antipsychotics are usually considered the agent to treat the hypoactive, delirious patient that you've got to get a control of. Haldol is still considered the gold standard. If you're going to use it with a geriatric patient, you want to use it at a small dose and go slowly with it. Haldol is probably the least anticholinergic and the least sedating of most of our antipsychotics. And it has the advantage it can be given PO, IV, IM. So, and it's the only one that we give IM or IV. Less likely to develop EPS if we're giving it IV, but you're more likely to develop QTC prolongation. So most hospitals will not push IV Haldol unless they're attached to some type of cardiac monitor. As the newer agents, the atypical agents have been out, there is more and more people using the atypical agents to minimize the potential side effects with the geriatric populations, the EPSs and that kind of stuff. There's just not as much literature to support that as there is for the Haldol. The only time you would actually think of using a benzodiazepine to treat a delirium is if you thought you had a benzodiazepine withdrawal or if you had an alcohol withdrawal. Those are really the only two times that you'd want to try to use the benzos. Otherwise, they would most likely, if the cause is a urinary tract infection and you're trying to give them Ativan or benzodiazepine to calm things down, most likely you're going to make things worse. So, the other critical thing is to treat, to resolve the causes. A lot of times people start getting a little better, and people stop, and then they have a setback, and they get a little delirious again, and then you kind of have to start over. The longer the delirium course, the worse the outcome. So you want to be really cautious about treating until you've got everything resolved. A lot of times they will go out of the hospital before the delirium is completely cleared up, and they will go out on an antipsychotic. The critical thing is somebody needs to be watching that antipsychotic and needs to be tapering it off as soon as possible. An antipsychotic started for delirium is not meant to stay on for months at a time. It's meant to stay there for whatever few days, few weeks it takes to completely clear up the picture. Okay, and then the non-pharmacological management is you want to DC the lines as soon as possible, get rid of IV lines, catheters. Try not to put them in restraints. Their literature supports the fact that the more lines that they are, the more confused they're likely to become, the more agitated they're likely to come and hurt themselves or someone else. Restraints tend to make things worse rather than better. Orientation, you want to frequently orient them. You want to frequently help remind them where they're at, what time of the day it is, who they are, and just the frequent reorientation to help them kind of bring their thoughts back together and get oriented. You want to address their sensory deficits, their eyeglasses need to be placed, hearing aids, those kind of things. Mobility, you want to get them up out of bed and get them moving as soon as possible. The longer you let them stay there in the bed, the worse it gets. So there are hospital programs that work real aggressively on the surgery patients to try to get them up out of that bed next day post-op and move, even if it's a step or two, and then keep going to minimize this. Sleep, you want to try to reset that sleep cycle, so you want to try to get them up during the daytime, moving around, doing activities, so they're more likely to sleep during the night. You want to do bright lights during the daytime to help orient the brain to this is a daytime, and then have as few lights as possible on at night, quiet at night, few distractions, those kind of things. Family involvement. A lot of times the families are willing to come stay with the patients, and they can help reorient them as where they're at, and help keep them maybe moving around and those kind of things. And so the studies have shown that the more that you do these non-pharmacological measures, the easier it is ultimately to get a good outcome from delirium. Okay, so why do we care about delirium? Well, if we look at the statistics from the American Delirium Society, over 7 million hospitalized patients a year have a delirium of some form. Over 60% of those patients are not recognized. Now, delirium, again, can still be there at discharge, and the longer it goes on without resolving, the worse the outcome. So the statistics are thought to be at least probably about half, or 45%, still have some form of delirium symptoms at discharge. At 3 months, 33% still have something going on. At 6 months, 21% still have delirium symptoms. The longer those symptoms are allowed to persist, the worse their outcome is probably going to be. If we look at an elderly person in a hospital that's matched for age and sex and race and all the other variables, if you look at a delirium person compared to a non-delirious person, a delirious person is much more likely to spend longer periods in the hospital, 21 days versus 9 days, higher probability of developing dementia a couple years down the road, 63% versus 8%. Higher mortality rates. 1 month, the mortality rate for a person with delirium is thought to be 14% versus 5% for a non-delirious elderly person. At 6 months, it's 22% versus 11%, and at about 2 years, it's 38% versus 28%. Higher probability of having a lower baseline of functioning and needing to go to a higher level of care. Higher probability of needing to discharge from a hospital into a long-term care setting. So at discharge, a delirious person is 47% likely to be discharged into some type of long-term care TCU setting versus 18% of an elderly person that did not develop delirium during that hospital stay. At 6 months, it's 43% versus 8%. At 15 months, it's 33% versus 11%. Okay, so that's kind of the fast review of delirium. We're going to talk about dementia. Again, dementia has been renamed in the DSM-V to be called neurocognitive disorder. What's called mild neurocognitive disorder is what you probably recognize as MCI, or mild cognitive impairment. And then major neurocognitive disorder is what you would recognize as dementia. Okay, so mild neurocognitive disorder, the most recent criteria, you have to have a modest impairment in cognitive decline, and the cognitive decline does not interfere, however, with the capacity of performing complex ADLs, driving, cooking, finances, that kind of stuff. It may be harder for them to do it. They may require more compensatory methods, clues, notes, checklists, those kind of things that they never had to use before, but with some modifications, they can navigate their environment and continue to live independently. According to the DSM-V, you want to document this cognitive decline based on informative information, ideally patient, but someone that knows the patient pretty well. And the DSMV suggests that you want to have a performance measure. They suggest neuropsych testing, neuropsychological testing. That's probably not realistic for most people. It's too hard to get, and with history and a good history and good information, a lot of times you really don't need a formal neuropsychological testing to figure out what's going on. With some basic screens, cognitive screens, depression screens, good history, you can pretty much feel pretty comfortable with the diagnosis without having to go to brain scans and neuropsychological testing. Okay, so major neurocognitive disorder is what is known as dementia. At this point, you have significant cognitive declines, and the declines have to reach a point that they interfere with the patient's or the person's ability to perform independent ADLs. The patient cannot cook meals, they cannot pay bills, they cannot correctly manage their medications without some assistance from outside to help them. And so the big difference is that a mild neurocognitive disorder can do that for themselves as long as they've got some compensatory ways to help manage that. A dementia has to have someone helping. Checklist and those kind of things just are not enough anymore. Okay, so these are the four dementias that are most common for the geriatric population. Alzheimer's is the most common. It's thought to affect probably 2/3 of the patients. The biggest risk factor is age. It is a progressive dementia. The duration is somewhat difficult to pin down because it depends at what point you diagnose the dementia itself. If you diagnose it early, then you could look at a person having a dementia, an Alzheimer's dementia, for 15, 20 years. If you don't diagnose it until later on, then it may look like they only have a dementia for 8, 10 years. The clue is a progressive gradual deterioration. It starts out with impairment of short-term memory, and as it gets worse and worse, then you have the impairment picks up the impairment of long-term memory. There's a high degree of caregiver burden associated with this, and so when you're managing an Alzheimer's patient, you're not just managing that patient, you're also managing the family and the caregivers that are trying to take care of them. And there's lots of literature out there suggesting that if caregiver stress that's not recognized and treated, a lot of times caregivers have poor health problems. Their diabetes are not well controlled, their heart disease is not well controlled, and they could end up dying before their loved one because of all the stress of trying to take care of a person with dementia 24 hours, 7 days a week over 10 years. It just is very stressful, and so when you're treating that dementia patient, you need to recognize it's just not the patient that you've got to be concerned about. The second most common dementia is somewhat in question. There is a group of literature that suggests vascular dementia is second. That would be a dementia associated with a stroke, and that's when you hear the stepwise deterioration. Their function at this level, something happens vascularly, they're down to a different baseline, they stay there, and so it's that stepwise, more abrupt change. And the cognitive impairments are more difficult to classify because it just depends on what part of the brain that's affected. The other one that is thought to possibly be second on the list is the Lewy body dementia. Lewy body dementia. It's thought to be frequently under-recognized. It is kind of a combination of Parkinson's disease and Alzheimer's dementia. You have 3 core features, and you need 2 of these core features. They can present with a lot of Parkinsonism, detailed visual hallucinations, and the visual hallucinations usually are small people and animals, and a waxing and waning of attention. There'll be some weeks that they look pretty sharp and some weeks that they look so very, very confused. And so you only need 2 of those 3. Other symptoms that kind of support the diagnosis would be REM sleep disorder. They can also have auditory hallucinations, delusions. They have some autonomic instability, so that makes them more prone to falling. A lot of times they will get misdiagnosed on the front end as a Parkinson's disease, get treated with the Parkinson meds, and they don't improve that much. The real difference that distinguishes them from a Parkinson's dementia is with the Parkinson's disease, it's just the motor Parkinsonian symptoms up front. The dementia occurs late in the disease. With a Lewy body, the dementia, the memory problems are occurring at the front end. So it's a timing picture for those symptoms. Lewy bodies progress a little bit faster than Alzheimer's. They don't respond as well to any of the medications. The other thing you want to remember about a Lewy body is they are super sensitive to medications, especially antipsychotics. And so you want to try not to treat their visual hallucinations unless they are at safety risk and you're forced to treat them. The antipsychotics are really detrimental to them. If you had to use an antipsychotic with a Lewy body or a Parkinson's patient, Seroquel is usually considered the choice one to use. A lot of times it's just helping the family understand this is part of their pathology. They're seeing these little people, they're seeing these animals. Most of the time they're not distressed by it. It's the family that's distressed. The patient's telling them, well, those frogs over there, or those kids over there, and they'll talk about them for hours at a time. It bothers the families a lot of times more than the patient itself. And so because of their super sensitivity to medications, you want to be really careful about not adding medications unless you just have to. The other one that I want to mention is what used to be called frontal temporal dementia, which is now called frontal lobar degeneration. That actually has very little memory problem on the front end. It may have some, your thinking may be more concrete, a little bit of problem with executive functioning, but this is the dementia that starts out with personality changes and changes in thinking and that area. And only as it progresses over 5-10 years do you start, only as it starts to progress do you start picking up an obvious memory impairment, of short-term memory, long-term memory, those kind of things. It usually develops a little bit earlier than an Alzheimer's dementia. It usually develops in the early 60s. Alzheimer's usually is 65 and on. If an Alzheimer's dementia develops before 65, it's called early onset. It's more likely to have a genetic predisposition before 65. But a frontal temporal dementia develops a little bit earlier, in late 50s, early 60s. More likely, men are higher risk for it. A lot of times, individuals who develop a frontal temporal dementia will become more childlike. They don't read social cues very well. Sometimes they get in trouble with the law. They've been a perfect citizen all their life, and then all of a sudden they're shoplifting. They don't seem to understand that that's a problem anymore. Well, I needed this. What's the problem? It's that total disconnect. Sometimes you'll have this person that's gone to church and did everything right all of their life, and then you've got a family member saying, well, so-and-so got a restraining order against them because they wouldn't come over, they wouldn't quit bothering me. I've asked them, I've tried everything, and they just don't get they don't get the social cues very well, and they don't understand that the social expectations very well anymore. Sometimes I've had frontal temporal dementias, sometimes be misdiagnosed as a bipolar. It's very unusual to have a person first diagnosed as a bipolar in their late 50s and 60s, and sometimes they almost look manic. They're irritable, they're agitated, their thoughts are kind of loose and disorganized, and I have seen that happen too. Okay, so dementia workup. Again, history, just like with delirium, history is essential. The history will point you to what type of dementia you're dealing with. Is this a progressive dementia that's been occurring over a long period of time? Families will tell you, well, you know, now that I look back over it, it was probably occurring 5 years ago, but they did not realize it had to get severe enough before families realized what was going on. And so maybe it's been going on for 5 years before they bring them to the doctor and say, hey, this is not right. With a vascular, it's that step-down pattern. With a frontotemporal, it's that the behavioral changes are the key. You really need an informant, because most of the time when you have the patient and you're trying to get the history from them, they don't realize that there's a problem. You know, well, I'm here because my daughter said I needed to come, but I'm doing just fine. I don't know what they're worried about. Left the stove on, called the fireplace, firemen come, but I don't know why that's a problem. It just is, they just don't process it anymore. And so you really got to have some help from other people. Physical exam, you want to do a good physical exam. You want to pay special attention to the neurological part of the exam. Look for signs that there might be something going on from a neurological standpoint. That'll point you towards a Lewy body. That'll point you towards a vascular. That'll point you towards a PSP or other possible criteria. And normal pressure hydrocephalus, you can sometimes pick up that this is not quite just a classic Alzheimer's, and that you may want to look a little more in depth. Basic laboratory test, you know, it's most commonly you look at CBCs, lights, thyroids. Thyroids can frequently be impaired in geriatric patients, so you want to make sure that you don't have a thyroid problem, either hypothyroid that makes them almost look depressed and withdrawn and apathetic, or a hyperthyroid that makes them agitated, irritable, and anxious and can't sit still and can look like a manic presentation too. Brain scans and neuropsychological testing really are not considered the standard. Not everybody really needs those. With good history and a good physical exam and some basic labs, if you feel like if you feel like that everything is falling into place, then you really don't need to spend the money on those CT, MRI. But if it's confusing and not making sense, then maybe you do. So not everybody has to have those expensive tests. Whereas 10 years ago, we were telling people that everybody needed those tests. So management. The real management for a dementia is the non-pharmacological management, trying to manage their behaviors and help families to manage things without using a medication, helping them to understand distractions and how to manage sundowning and those kind of measures. The more there is no FDA medication approved for behavioral symptoms of dementia. It just does not exist. Frequently you'll see depressions, anxieties become apparent before the formal diagnosis of dementia. Sometimes an antidepressant will help some, but it's not going to be the wonderful panacea that we had hoped. The cholinesterase inhibitors are what are FDA approved for the delay in the memory progression. It does not stop that progression. It does not reverse it. It can delay it to let them stay at a higher level of functioning, to give them a better quality of life. And that's something you have to remind families every time you come back in, that the medications are delaying this, they're not stopping it. The other one, the Namenda, actually targets the glutamate receptors, glutamate modulators, and it is meant to be an add-on to the cholinesterases to help them work better. You want to be sure to address the caregiver and the caregiver stress issues, because if the caregivers are not doing well, they're not going to manage the patient non-pharmacologically very well. They're going to get frustrated and irritable, and that's not going to go well. When the person is first diagnosed with dementia, early on especially, if they still have enough capacity to make decisions, you want to encourage them and the family to start making legal decisions. Make sure the wills are up to date. Make sure that the powers of attorney are up to date and those kind of things, because they really do not, because once you get to that middle and late stages, they can't make those decisions. And so you're just kind of left with either family having to get guardianship, or it becomes more difficult to manage things. And then you're just kind of left with them not being able to make the decisions that they could make on their own at the front end. Okay, let's talk quickly about depression, because we're running out of time. But depression, you need 5 symptoms at least over a 2-week period of time. It should be a change from previous level of functioning. And the symptoms should be severe enough that they caused impairment. One of the 5 symptoms needs to be a depressed mood or anhedonia, lack of interest, nothing interesting anymore. The Siggy CAPS is a mnemonic to help look at the symptoms common to depression. Sleep, either they're sleeping too much or sleeping too little. Interest, they've lost interest. Guilt or worthlessness. Geriatrics are really prone to develop a nihilistic guilt syndrome, that they've done something bad, they can't quite figure it out, but it has to be bad if they're feeling this bad. Energy, either too much, either they're agitated and irritable, or they're real slowed down. Concentration and memory can be impaired. A lot of times, a depressed person, a lot of times will answer "I don't know" to questions and not even make an attempt to answer. Sometimes a dementia patient will give you an answer. It may be wrong, but they will give you an answer. But sometimes the concentration and the memory can become so slowed down and impaired that it looks like a dementia, and that's called the pseudodementia of depression. So you've got to treat the depression and get that out of the picture before you can figure out, is this a depression of dementia, or is this a depression that's so bad it just looks like a dementia? Appetite, either they're eating too much or too little. Psychomotor activity, either it's real retarded and slowed down or real agitated. Suicidal ideation and death, a preoccupation with not wanting to be here anymore, thinking of suicide, things are so bad that there's no reason for me to go on. Depression, it increases the use of the healthcare systems, increases functional deficits, and decreases quality of life. There's a difference between what we call early onset depression, which is depression that you've had in your earlier years, you have in your 20s, your 30s, your 40s. That usually manages pretty well with our medications. It's the late onset depression, the depression that occurs first in a person 65, 70. That is more difficult to treat. It's harder to get good results with that, managing that depression. It's much more likely you hear somatic complaints, especially GI complaints. They complain of a lot of constipation, a lot of stomach pain. They get worked up. Nothing really is found. A lot of somatic complaints. Anxiety is frequently a component of late life depression. And so anxiety, depression kind of go together, and they become fixated on that, and just adds to the whole picture. A lot of feelings of helplessness. Pain is harder to manage. They're more socially drawn. They have any medical comorbidities get worse if you don't try to manage this. Heart disease becomes worse. Diabetes is not well managed. They do not have as much of a family history of depression as the early onset people do. Poor response to treatments. Cognitive complaints are more prominent, harder to resolve, more impairing. Suicide is much more common in the geriatric population. We used to say it was the highest suicide risk. In 2013 was the last statistics that I could find. The highest risk now is the 45 to 64 year age group. The 85 plus has now got the second highest rate of suicide, but males are still much higher risk of completing suicide than females. Females actually probably make more attempts by overdosing, but the males are usually use more lethal methods, the gunshot wounds and those kind of measures. Caucasian males account for the biggest part of the suicides when you look at race. Treatment of depression, therapy, medications, ECT. ECT is good for psychotic depression. It's good for suicide. It's quick, no drug interactions. It's actually more effective than medications. The mantra is start low, go slow. You frequently are going to wind up at a dose that you would have an adult person on. It's just you've got to go a lot more slower to get there, and the geriatrics are much more sensitive to side effects, and you're much more likely to have problems with side effects. SSRIs are the most common ones, usually are considered first line. SNRIs are we go to next. TCAs usually are considered third line because of their side effects, anticholinergic and those kind of things. Here's your common side effects of the SSRIs. If you had to use a TCA, nortriptyline, which is the least hypotensive, or cypramine, which is the least anticholinergic, is usually considered the choice ones. Okay, so to summarize, the 3Ds are common. They often overlap and coexist. So just because you have depression does not mean you can't have dementia, does not mean you can't have delirium. You can have all of it. They often go unrecognized, and they contribute to a significant amount of morbidity and mortality. This is a chart that you can kind of read on your own that kind of separates the delirium, dementia, depression by different categories. That kind of helps you figure out what you might be looking at. Okay, so I think that ends it. What questions do you have?
Is there any way to prevent the dementia in the hospital? Since you're talking about, delirium in the hospital.
The quicker you get them out, the better. Keeping them well oriented, using the sensory stuff, a few drugs as possible, all those stuff that makes it worse. The more you can in and out and not be tied to IV lines and restraints and that kind of stuff.